everyone. I am going to talk about basic neuroscience, translational, but not in rats, neither in mice. And you can do basic neuroscience in humans. It all depends on your question, actually, in my mind. I'm not going to talk about what I spoke yesterday, and I hope you've been here because some of the background is the same, and my thanks to my lab and the funding agencies. But I'm going to focus today on one study supported by a smaller grant. And just to remind you again of the IRISA model, where we emphasize the role of the prefrontal cortex as underlying impairments in response inhibition and salience attribution, explaining the core clinical symptomatology of addiction and the fact that people with addiction have this continued persistent drug seeking and use despite catastrophic consequences to behavior, despite the decrease in pleasure derived from the drug. And I also reviewed this one last slide that is the same as last time, just to remind you all that we have, when we use fMRI or any other type of tool, you can use also EEGs, you can use many behavioral tasks, it's a very persistent and constant and reliable valid type of measure where you have hyperactivations, drug cue-related hyperactivations in people with addiction as compared to healthy control subjects. This is across many fMRI studies comparing addicted individuals to people who are not addicted, exposed to drug-related cues, mostly pictures or paraphernalia, and showing these increases in signal across the board, not only in reward regions in the brain, in subcortical regions that have to do with either habit or reward, but also in regions that underlie salience attribution and executive functions and inhibitory control. So you have these impairments and hyperreactivity to drug cues at the expense of other alternative reinforcers. And we know that this type of hyperactivation to drug-related cues is a predisposing factor. It correlates with craving and it predisposes individuals to relapse. Despite the fact that we know about these vulnerabilities in the brain and behavior, people with addiction barely receive any treatment. These are statistics from 2016, but it's the same also later on, where 93% of people with addiction do not, or with substance use disorders, do not receive any specialized type of treatment. Nowadays, the numbers are a little better, but still, I just checked them this morning, 85%, the majority of people who need treatment for substance use disorder do not get any treatment, maybe because of stigma, maybe because of access to treatment, or maybe because of the perception that, well, you know, addiction is this and not the other thing, it's more a moral thing, it's not a type of brain disease, maybe because of the perception that methadone, for example, or buprenorphine, they're enough. They reduce craving, and this is basically their solution. So we're not thinking about treatments that will be specifically targeting these core impairments in addiction, and this is what the talk is about. How do we use neuroscience and preclinical models, but to design interventions that help people outside the lab and actually in the clinics, because they really need our help. Okay, so to design interventions that are helpful, we have to think about core impairments in addiction. And in this type of hyperactivations to drug-related cues, there is a huge role for conditioning and maybe impaired extinction. So in conditioning, you have drug-paired cues, such as, for example, just a neutral cue, like a spoon that I spoke about yesterday in a different context. Just by the mere pairing with a drug paraphernalia, and this is the drug, it acquires this type of incentive properties, and it becomes a conditioned stimulus that causes a conditioned response. And because of this type of conditioning, the thought was, okay, so let's extinguish that type of association by just omitting the drug outcome, and maybe we can then normalize back the stimulus to become neutral again. So extinction, this type of learning, a new learning, is a VMPFC, ventromedial prefrontal cortical guided learning process. I spoke about the VMPFC also yesterday in how it explains this inability to shift behavior flexibly when contingencies in the environment change. So extinction actually relies on the VMPFC, and in the general population you have enhances in VMPFC signal, this is the fMRI Bold study, to conditioned stimuli over the course of fear extinction. This is results by Elizabeth Phelps. It is also associated with cortical thickness of the same region. But in cocaine addiction, we showed that during the course of extinction, here it was drug Q and manu extinction, actually VMPFC shows decreases in fMRI signal in responses to extinction. And this type of deficits in the VMPFC to extinction learning have also been shown by others during fear extinction. We also showed that gray matter volume is reduced in the same brain region, not only in cocaine addiction, but also in opioid use disorder. And these type of impairments may be contributing to this enhancement in drug Q reactivity in the VMPFC that I showed you in the slide before. And that I showed you also yesterday with the pictures and the movie. So maybe because of these impairments, extinction-based Q exposure therapies in addiction yield mixed results. They're not always as successful as you want them to be. And maybe because also the original learning, that original conditioning, and is not replaced by the new learning during extinction, so it does not erase the original drug Q memory, but it promotes basically new drug Q no drug association, which is then susceptible, so the original memory, that original extinction conditioning is susceptible to reemergence, and the conditioned response reemerges maybe through reinstatement, renewal, or spontaneous recovery. So how can we enhance standard extinction learning? One way is through reconsolidation. So during this drug Q conditioning, the original conditioning, you have consolidation of a Q drug memory, and maybe we can render that memory label. We can do that during reconsolidation, where memory is reactivated. And then the memory can be either enhanced during this reconsolidation window, or it can be reduced by, for example, conducting extinction during this reconsolidation window. And this type of intervention, where you do extinction during reconsolidation, has been shown to reduce cigarette and heroin craving. This is actually in collaboration with Yavin Chaham. And it has been replicated in methamphetamine use disorder. So where you do extinction, you extinguish that original memory, you are acquiring something new, but during reconsolidation, when the memory is labeled. And that reduces craving. It has been shown in rodents and in humans. And this type of reconsolidation is actually associated, and extinction during reconsolidation is associated with reduction in VMPFC activation. So the inhibitory control that is required by the PFC is no longer needed by this reconsolidation. So you can bypass the VMPFC, which is an important thing in the disorder like addiction that impacts gray matter volume in this region and the function of this region. I'm going to reiterate this statement again. Okay, how else can we enhance standard extinction, the learning of this new memory? Because this type of behavioral intervention is bound to be modest. So we thought about methylphenidate. Methylphenidate is a partial dopamine agonist. It's Ritalin, basically what we give children with ADHD, okay? So it works very similarly to cocaine. It blocks the dopamine transporters, enhancing extracellular dopamine. It does not increase craving or a high when administered orally. It's very different than when administered IV. It enhances salience of food stimuli and math tasks in health. It bolsters cognitive functions by increasing signal-to-noise ratio and activity in the brain regions that underlie accurate task performance, and this is work by Nora Volkov from a while ago. Oral methylphenidate decreases risk-taking by enhancing inhibitory control in other psychopathologies that affect prefrontal cortical integrity and function, for example, frontotemporal dementia, ADHD, TBI, and stroke. In humans, we showed that oral methylphenidate changes the prefrontal cortical substrates of drug use salience and inhibitory control, reorganizing VMPFC function in cocaine addiction. We have a whole series of studies on that. In rodent models, methylphenidate facilitates extinction and its retention. Again, to reiterate the point I just made, methylphenidate has low abuse potential and it is viable as a therapeutic agent when orally administered. An interference with the binding of a drug to a certain target, but a slower pharmacokinetics is extremely valuable in management of other drug addiction, for example, heroin and nicotine, with methadone, for example. So our hypothesis was that in a combined approach, using methylphenidate during reconsolidation, we can modulate drug memories in people, in humans with addiction. It's a small study. We had 18 people who are addicted to cocaine. Most of them are men. Most of them are white, actually. They're in their early 40s, average education, average IQ, a little bit slightly elevated depression and anxiety, which we see always with our addicted individuals. And they have at least a decade of cocaine regular use, and they are abstinent for a while because most of them are actually inpatients. So they have not been using cocaine or any other drugs in the last 30 days. It is a randomized double-blind crossover design, meaning that the same sample of people come back to us many, many times, the same way we always like to do with our studies, and they come back to us a week apart to receive a different pill. Once they receive methylphenidate, another time it's randomized crossover, and they receive placebo. They do not know what they're receiving. They cannot guess it. We are giving methylphenidate at 20 milligrams where people do not feel anything, basically. They cannot report what they are getting. The experimental design is as forward. The conditioning phase is done outside the scanner, and here we just condition. We use pictures, and we show them a short clip of a drug-related paraphernalia or drug consumption. The conditioned stimulus is just a picture, and the picture can be of buildings or of people. And we have two types of drug-related conditioned stimuli. We also have neutral unconditioned stimulus, so just a person holding a pen. And 3 hours after this conditioning and consolidation of this learning, this is when we give the pill, and the pill can be either the methylphenidate or the placebo a week apart. 1 hour after pill administration, this is when methylphenidate reaches peak effects in the brain, we perform retrieval, which is the reconsolidation. So reconsolidation means we are just reminding them of this original conditioning. And we are reminding them, you see those cues, the CS pluses in green? So they were a priori designed to be reminded CS pluses, and in purple there are non-reminded CS pluses. And this is the real, extremely controlled type of comparison. So during this window, the retrieval, the reconsolidation, we just show them this type of to be reminded cues. Notice that we also had a flanker type of condition during conditioning because it's a very boring task. People are doing basically nothing. It's passive viewing of images. So we're checking that they're awake, and then we remind them certain of the CS pluses, and then we do the extinction. And during extinction, meaning that we show them all of the CS pluses, reminded or non-reminded, and the CS minus. And again, this is extinction, so the US, the actual drug-related picture or the neutral picture is not being shown. Okay, our hypothesis is that both methylphenidate alone or reconsolidation, that reminded intervention alone, will actually normalize the VMPFC impairments in extinction we previously shown. But it will do that in a way that shows over-reliance on the PFC, so not in a normal way that is shown by the general population, and that only during reconsolidation combined with methylphenidate, we will see normalization of the VMPFC response similar to what we see in the general population. So just as a check, we checked also their methylphenidate in the blood, and indeed, on the day they receive methylphenidate, we can show that they have higher methylphenidate levels. Okay, so the first finding in the VMPFC is a replication of our finding from the previous study where we showed impairment during standard extinction in people with cocaine addiction. So this is VMPFC response. We're analyzing it throughout the extinction in run 1, 2, and 3. So as learning progresses, we have VMPFC decreases during standard extinction in people with addiction. And this replicates our previous study here. And it supports the fact that people with addiction have compromised ability to form and or maintain new associations for cues that used to predict drug-related reward and no longer predict, and they still respond to them. And it also is consistent with these impairments in learning that the drugs or the cues are no longer as valuable. If you expose them to those reminded cues, so that's the reconsolidation window, you indeed enhance VMPFC response. And this is the same type of response that the general population shows during standard extinction learning, but people with addiction show it during reconsolidation. So you have over-reliance on the VMPFC, and the same over-reliance on the VMPFC when you expose them to methylphenidate alone. So this is methylphenidate and non-reminded trials, and you see the same type of response. But only, so here, so both reconsolidation alone, methylphenidate alone, now people with addiction look like the general population during standard extinction learning. But only when you combine methylphenidate specifically during reconsolidation, now you have a decrease in the VMPFC response, exactly what you expect. This is based on Daniela Schiller's work with Elise Phelps, that the VMPFC now shows decreases during this reconsolidation window. So you bypass the need for the VMPFC during reconsolidation, and we show that only in this combined type of approach. Entirely consistent with our hypothesis that you need this combination to normalize VMPFC function in people with addiction. Okay, we checked not only the activation of the VMPFC, but also its connectivity with the amygdala. So this is psychophysiological type of interactions, and so connectivity of the VMPFC with the amygdala. During placebo, early versus late extinction trials, during reconsolidation, when there is no methylphenidate, during placebo, you have enhancement of the connectivity between the VMPFC and the amygdala. So this is enhanced, this is abnormal type of reaction because you have over-reliance on the VMPFC that then decreases when you have methylphenidate. So not only methylphenidate plus reconsolidation reduced activation of this region, it also reduced its connectivity with the amygdala, and this is exactly what we expect, this reduction. So this increase indicates abnormal need for the inhibitory control functions of the VMPFC over the expression of the conditioned response. If you look in fear extinction, this is work by Gregory Quirk, the infralimbic cortex, which is the homologue of the VMPFC in rodent models, it actually stimulates intercalated cells in the amygdala that then cause inhibition of cells in the central amygdala to reduce conditioned fear responses. So you need all this type of circuit. You need the control of the infralimbic cortex to reduce conditioned responses. So here in placebo, during reconsolidation, we need the VMPFC control functions. But with methylphenidate, we no longer need it. We can bypass the VMPFC response in people with addiction with impairments in this region. And this interpretation receives support also with correlation analysis, where you have these increases in VMPFC responses. This over-reliance of VMPFC was correlated with drug-seeking behavior. As we assessed the next day, people came back to us after each fMRI day where we assessed drug-seeking. I can explain to you if you have questions about that, but we have a very reliable and valid task to assess drug-seeking that correlates with drug use outside the lab and predicts drug use. So the more these abnormal VMPFC increased responses, the more the drug seeking the next day, but only during placebo and not methylphenidate. And the more this response, this abnormal response, the longer the cocaine regular use. And this type of individual differences also are very important when thinking about how to use it clinically. Okay. So to conclude, how much time I have? 5, perfect, okay. So to conclude, what I showed you here is the importance of combining pharmacological type of approaches guided by preclinical type of thinking and very basic neuroscience to enhance a certain cognitive function or behavioral function in people with addiction that targets a core type of trait in addiction. So here we use methylphenidate, a dopamine agonist, as a cognitive enhancer. It builds on work where we showed that it normalizes the ability to attribute salience and value in the environment. It enhances inhibitory control. It also enhances resting state, functional connectivity, networks in the brain. And now we show how it also normalizes reconsolidation. This paper is now in press. It's under embargo. There are many open questions to this type of approach. In order to design it as an actual clinical intervention, we have to compare it to other type of interventions. What would be the dose? How many times would we need to combine methylphenidate with this reconsolidation approach? What is the duration? What would be the clinical impact? Can we affect not only people with cocaine stimulant addiction, but also opiate addiction? It opens a whole host of questions. But I think that this alone needs to be considered in context of other treatments that we can think about. And yesterday you heard about TMS. In my lab, we do TDCS, transcranial direct current stimulation. It is a portable device that people can actually take home and be taught to self-administer. And maybe it can enhance TMS effects. Maybe it can enhance this type of effects I showed you here, because you can self-stimulate the dorsolateral PFC affecting the ventromedial PFC. And we have now already 2 studies showing how TDCS of the right VLPFC reduces craving in people with cocaine addiction, especially when combined with another cognitive intervention, which is cognitive reappraisal of drug-related cues. So maybe we can combine this type of non-invasive approaches, maybe as a function of time, maybe as a function of individual differences, and in addition to mindfulness. And this is another intervention that uses cognitive reappraisal of drug-related cues, enhances and increases savoring of alternative reinforcers together with mindfulness training. And we have results now showing how it increases abstinence in people with cocaine addiction. So I think that what we need to develop is a thinking of how to use a combination of approach and targeting individual differences based, for example, on Anna Zilverstein's talk yesterday about people who show, let's say, compromised control versus enhanced reward seeking versus negative emotionality. So maybe this type of methylphenidate together with reconsolidation would be best to reduce this type of drug cue conditioning. Maybe those who are most predisposed to reward seeking, they would be most amenable to this type of intervention. Those who need inhibitory control type of enhancement, maybe we can add TDCS. And those with negative affect, maybe we can somehow add also mindfulness. There are many things that we can still explore. But we need to optimize our interventions both based on the individual characteristic and based on their state in the addiction cycle, because it is a cycle different from many other mental health illnesses. And again, thank you for Nelly Klein, who is the co-chief of my lab, and thank you for your attention.